Thank you. Thank you very much for having me. I'm sorry that I cannot say hello in German. I could say it in Dutch if that was any help. And I'm sorry that I'm not here today in Berlin with you. Let me just share my screen. Is this the one? Oh, God. Sorry, I'm having slight difficulty sharing my screen. Oh dear. Have you got a copy of my presentation?
I will forward this to our technical staff.
I have a copy, Hannah, if you want me to share.
For some reason, it's not allowing me to share my screen. Sorry.
So we have to check whether we can put your presentation on the screen, maybe.
I'm sorry about this, everybody. We did, maybe everybody can have a quick stretch while we do this, because we did we tested it earlier. Open system press.
Hannah, I can share it for you if you want.
Yes, maybe this is a possibility that Alakos, okay. Yes, yeah, okay.
Fine, thank you. And then I'll just keep on saying.
That's next, great, thank you.
Yeah, it's good.
Thank you, Alakos. Just give me one moment to set myself up. Okay, thank you, Alakos. Can we have the next slide, please? Next slide. I think, Alakos, you may have
now my computer is blocked. Sorry for that. Probably because I don't have the rights anymore. So let me check.
Okay. Privacy.
No, I cannot move the slides. Sorry, Hannah.
Okay. Can you go to the next one?
Yes.
Okay. Thank you. So after that rocky start, I'm going to talk today on how is access to health services and healthcare systems working for people with disabilities. I am from the London School of Hygiene and Tropical Medicine, but I'm going to present a lot of the work that I have been doing with Phyllis Height and others on the Missing Billion report. So if you go to the next slide, I want to start by rooting what I'm going to say within people and people's experiences.
Hannah Kuper, can I just interrupt you for a moment, because we have now your presentation online.
Okay.
We have it uploaded here locally, but you can always say to us when we have to put on the next slide on the screen.
Okay, so okay. I'll just say next slide. Sure. So I think we should be seeing a slide now with three. It should be the third slide, so a slide with the pictures of three young men.
Just a moment, please.
Sure.
We are working on it. That's a live performance under difficult circumstances.
Yeah, my apologies. We did test it all out, so something's gone wrong in the meantime.
Just a second, please. So, okay.
Wonderful. So we can go to 2 slides down, so the third slide.
So we have your.
Yeah, here we go. So I want to root my talk in the experiences of real people, and these are 3 young men in the UK. So the first is Oliver Mcgowan. He was a young man with autism and also had epilepsy and learning disabilities. He'd been prescribed an antipsychotic medication, even though his family and he himself had made it very clear that he was intolerant to those drugs, and he died as a result from a rare reaction. The second man is a man called Richard Hanley, who is a man with Down syndromes. He died of complications from constipation, and that resulted from him having poor diet and a repeated failure to detect and treat his condition. And the third man is called Conor Sparrowhawk. He was a man with learning disabilities, epilepsy, and autism, and he died while he was in an NHS facility after because he had a bath and had a seizure within the bath because the door was locked. And all of these deaths are tragic, but also preventable deaths. And as a result of these kinds of deaths in the UK, a confidential inquiry was launched as to why people with learning disabilities were dying younger and what was happening. Next slide, please. And this was the main finding. So that on average, people with intellectual disabilities in the UK, men were dying 13 years earlier and women were dying 20 years earlier. And that 1 in 4, 1 in 5 people with intellectual disabilities died before the age of 50, compared to 9% in the general population. And then what you could see is more severe the intellectual disability, the younger the age of death. And so that people with profound intellectual disabilities were dying on average at 46 years in the UK, compared to 78 to 83 in the general population. If you go to the next slide, what they found overall was among people with intellectual disabilities, half of deaths were avoidable and 37% of deaths would have been amenable to good quality healthcare. So a very high proportion of deaths among people with intellectual disabilities in the UK was because of problems with healthcare. So we go to the next slide. So this is very important to individuals, but it's also important much more broadly, as we've already heard. Health is a human right. It's respected in the CRPD and in the rights, in the laws of most countries. So this is really a very important issue that we need to do something about. Next slide, please. So I'm going to ask a couple of questions in my talk, and the first is, are people with disabilities more vulnerable to poor health and early mortality? And if so, why? Next slide. Well, first of all, it's already been acknowledged that there are about 1 billion people with disabilities worldwide, and this includes people with a range of ages, although disproportionately disabilities found among older people and people living all around the world. Next slide, please. An underlying disability are many different kinds of impairments. So they can be musculoskeletal, neurological, mental health, or sensory. Next slide, please. And what we also know is that disability is not just diverse in terms of age and gender, impairment type, and where people live in the world, but also the experiences of individuals. People have complex lives. They may have a range of barriers that they experience. There may be positive factors, there may be poverty. But we also know that on average, people with disabilities experience difficulties with employment, education, poverty, stigma and negative attitudes, social exclusion and violence. And all of these different factors are very important when we start thinking about the healthcare needs and access of people with disabilities and what kinds of things we should address. Next slide. So the first thing I want to say is there's lots of evidence that people with disabilities have a higher vulnerability to poor health. Next slide. So this is from Britain, and this shows that even in Britain, people with intellectual disabilities, as shown in the confidential inquiry, have poorer physical health than people in the general population without disabilities. So they may have poorer lung function, obesity, and be more likely to be admitted to hospital. And this kind of pattern we see in all places of the world, generally poorer health among people with disabilities compared to people without disabilities. Next slide. And there are a couple of different pathways for this. So first of all, people with disabilities by definition have an underlying health condition and impairment, which may exacerbate poor health. As I've already said, people with disabilities experience poverty and exclusion and poor quality healthcare more often on average. There may be difficulties accessing healthcare, which means to poorer diagnosis and control. And people with disabilities may have more risk factors, such as obesity and smoking, all of which leads to poor health on average. Next slide. But there are two other factors. So people with disabilities may have vulnerability to poor health. They also need regular health care. So whether that is to protect from COVID or receive immunizations or sexual and reproductive health care. And as is discussed more in one of the later panels, many people with disabilities may benefit from specialist medical treatment, rehabilitation services, and assistive devices. So So the health needs of people with disabilities are really threefold. Next slide. But let's look at some examples, and this is what we thought about within the missing billion. So when you think about people accessing healthcare, it can be quite complex. So the first is an example, Dustin, of a man with intellectual disabilities. Imagine that his teeth hurts and he needs to, he lives in a group home, but he needs to have dental surgery. Or a man in Malawi who has a son with a hearing impairment, but he's very poor, and how is he going to get treatment for his son? Or a woman with a physical impairment in Ghana who is pregnant and expecting her child, and what kind of barriers will she experience when accessing healthcare? Or a woman with a visual impairment and HIV who needs to have ARVs and the difficulties with obtaining or taking drugs. Or finally, the example of a woman who has a child in Brazil with congenital Zika syndrome who has very complex healthcare needs, but perhaps also something simple like an ear infection. And so you can see that the great diversity of disability will also impact on the experiences of people in accessing healthcare and the different barriers. Next slide. But barriers to healthcare access are often, for people with disability, are often put into these different buckets. So things like inaccessible facilities, financial barriers, lack of assistive devices, poor healthcare worker skills, lack of accessible transport, or stigma and negative attitudes. And although those are true, in the Missing Billion report, we've started to think about different ways that we can think about these barriers along the healthcare seeking journey that can help us to think of different ways to intervene. Next slide. So we can think about the demand, we can think about the healthcare journey, which involves realizing that you have a need, deciding to seek healthcare, reaching the venue, accessing the healthcare, engaging with healthcare staff, and then having treatment or follow-up care. And so from the demand side, from the person with disabilities, there may be difficulties in understanding that there is a need for healthcare services or how to seek healthcare services or being in control of that decision. Or there may be difficulties with affordability of care, for instance. Next slide. On the supply side, from the healthcare worker side, there can be problems with the health provider infrastructure and capacity. So for instance, lack of accessibility. There can be issues around lack of healthcare worker knowledge, attitudes, and capacity because of poor training of healthcare workers about disability. But these barriers come from somewhere. They don't come from nowhere. So if we go to the next slide, we think that they're underlying drivers which need to be addressed. And this tallies very closely with what Alakas was saying in the previous presentation. These barriers come from a lack of data and evidence on what the issues are and how they can be resolved. There is often good legislation and policy regarding inclusive health for people with disabilities, but often poor enforcement, that a policy is no good if it's not interrogated to see whether it's being fulfilled with penalties if it is not. There is a lack of financing and funding for disability inclusion, and often there's a lack of leadership and management of the disability inclusive healthcare. So that what we see in terms of barriers really result from these underlying system level drivers. Next slide. And so there are lots of examples of this. So for instance, most health plans don't mention people with disabilities. There are few rehabilitation specialists in sub-Saharan Africa, and many healthcare workers do not receive training on disability. Next slide. So what we see is gaps in the healthcare seeking journey, but what we also see is gaps in the whole range that should be covered in universal health coverage. So universal health coverage should include promotive, curative, preventive, rehabilitation, and palliative care. And across all of those, there are gaps that people with disabilities experience in accessing those services. Next slide. And this really matters. So as a result of all of these gaps, health outcomes are worse in all areas of SDG 3. People with disabilities are 3 times as likely to have diabetes, 50% more likely to experience catastrophic health expenditure, 10 times more likely to be seriously ill as a child, twice as likely to be malnourished as a child, twice as likely to have HIV or AIDS. And the health system reason for low life expectancy, as we saw for the UK, is 40% of cases. And a recent study also shows that this translates into higher mortality, so 4 times higher for children with disabilities. And as Phyllis will present later, within the COVID pandemic, in the England and Wales, 59% of COVID deaths have been among people with disabilities. So this really, really matters, these health system gaps. Next slide. But there's still large information gaps. There are lots of gaps about how the health issues facing people with disabilities, the barriers in different parts of the world, what coverage is like. There are lots of gaps in terms of UHC monitoring for disability. And so, as Alaka said, it makes it difficult to advocate to ministries of health about what they should do. Next slide. But what is clear is disability is not yet recognized in global health. And these are a couple of examples from the SDG 3 action plans, UHC, and declarations of health, which again and again fail to address disability or rehabilitation in a meaningful way. And at the moment, disability is still, and rehabilitation are still not within UHC monitoring indicators. Next slide. And this situation matters. It matters, as I've said, because if we continue to neglect people with disabilities, we will not reach the SDG 3. We will also fail to maximize the individual's quality of life and that of their families. We will fail to comply with international law and national law. That we believe that if health services are inclusive of people with disabilities, they'll be better for all. And it will also help in the achievement of all SDGs. Next slide, please. So I'm going to give a brief example of HIV. Next slide. So we were involved in a study in Malawi which compared HIV positive children to their sibling who was HIV negative. And you can see that overall 33% of HIV positive children screened positive for disability compared to 7% of their siblings, and that was across the range of different functioning types. Next slide. And this was confirmed in a systematic review of the prevalence of impairment among people living with HIV, that this was very high. So for physical impairment, hearing impairment, dementia was present in 1 in 4 people living with HIV, and cognitive impairment and motor delay even more common. Next slide. So this is a slightly complicated slide, but it's trying to argue that if we continue to neglect people with disabilities, we will fail to meet HIV targets. So HIV targets are to reach that 95% of people with HIV know their status, are on treatment, and have undetectable viral load by 2030. It's the 95, 95, 95. So this is an example for Southern Africa, where currently, if we look at the red line, 84% of people with HIV know their status. But we can assume that about a quarter of people with HIV have disabilities, and we know that people with disabilities have a lower testing rate than people without disabilities. So a blue line shows people without disabilities who know their status, which is higher than the average, and the yellow line shows people with disabilities who know their status, which is a lot lower than the average. So to increase the testing coverage by 2030 to reach this 95% status, it means that 98% of people without disabilities would need to know their status to compensate for the fact that 78% of people with disabilities would know their status. So that is incredibly difficult to achieve. Next slide. But if we think of people who are left untested, so this is 1,000 people, this graph shows a hypothetical 1,000 people with HIV, the proportion who are untested, which will go down over time, it means that at some point, the majority of people who are untested will be people with disabilities. And so just taking very specifically the example of HIV and reaching testing targets, we will not be able to do that if we allow this situation to persist, that people with disabilities are not getting tests to the same extent as others. Next slide. But even within HIV, where it's such a strong relationship with disability, it's continued to be neglected from HIV national strategic plans. And these are just 4 examples of Malawi, Zambia, Nigeria, and Haiti, where it is not sufficiently addressed. Next slide. So what should be done? Next slide. So I started by showing you the confidential inquiry into premature deaths of people with learning disabilities that happened in the UK. And as a result of these really horrifying early deaths, there were a range of recommendations that there should be data collection about people with learning disabilities through the NHS. There should be reasonable adjustment, which should be audited to make sure that it happens. There are NICE, which means healthcare guidelines about the treatment of people with learning disabilities. They are offered annual healthcare checks, and there's now mandatory training of healthcare workers about learning disability. And that's just some of the recommendations. And the recommendations came from having very clear evidence that people with learning disabilities were being left behind and dying unnecessarily and early. Next. So if we think again about this how that maps onto the healthcare framework that we set out earlier about the different barriers, we can tackle different things in terms of the systems like governance, leadership, health financing, data and evidence, the demand and supply side, so that we can get better outputs and outcomes. And we need to, as Alaka said, we need better evidence about what should be done here. Next slide. But for instance, with governance, countries should have laws and policies that protect the rights to healthcare for people with disabilities, and these should be monitored and enforced. There should be clear representation of people with disabilities in the leadership of Ministry of Health and health sectors. Health financing and health insurance coverage should be available for people with disabilities and allow adjustments. And there should be evidence on the health needs of people with disability and monitoring of their inclusion. And this is currently lacking. And as I said, UHC indicators are currently ignoring disability. Next slide. And from the demand side, people with disabilities need to be supported to make their own decisions about healthcare, which they can afford. And there should be training of healthcare workers about disability. It should be made sure that infrastructure is accessible, and as will be discussed later, that specialist health services is available. Next slide. And I go back to it again, that what isn't counted doesn't count, and that some of the changes that have happened in the UK, previous slide please, that some of the changes that happened in the UK are because of those, because of the information that was collected in the confidential inquiry. I'm going to skip the next slide. Please skip the next, go on to the next one. And that with those kinds of changes in place, we can achieve good access, equitable access for people with disabilities. It means that we will fulfill rights. It means that people can live good lives, and that the tragedies of these kinds of deaths, early deaths, unnecessary deaths, can be avoided. Thank you very much. Next slide. Thank you.
Thank you, Hannah Kuper. Thanks for this presentation.